Hello and welcome to the EML device seminar. This is an educational seminar designed to elucidate the clinical utility of the EML device, which stands for the Erchonia Medical Laser, a technology designed and developed in the United States as an alternative form of care for the treatment of acute and chronic pain as well as post-surgical pain. We will be discussing the pathogenesis of pain as well as mainstay therapies to simply manage the pain and the clinical utility that the EML device can provide. Pain is a complex syndrome, and it affects millions of individuals worldwide. Pain is described as neuropathic, nociceptive, or a combination of both. Very quickly, neuropathic is a disease or injury to the peripheral or central nervous somatosensory system. Nociceptive is the disease or injury to somatic structures, and somatic structures are referring to skin, muscles, and tendons. Sensitization of primary afferent nociceptors is then further aggravated by the upregulation of pro-inflammatory cytokines like tumor necrosis factor alpha and other pro-inflammatory cytokines, interferon gamma, elements that further exacerbate the elements of pain simply because they are sensitizing these afferent nociceptors. That then increases the experience of pain. So there's a complex pathogenesis of pain, numerous etiologies that correspond and correlate to the manifestation of pain. Now, with this development of pain, we see specific models or outcomes that can actually exacerbate the pain, although there is no further degradation of the tissue. The structure has stabilized, but because there are remnants of the traumatic injury and the pain remains, there are models now that can further exacerbate the pain. And the primary model is the pain adaptation model. This is very easy to understand when explained in very basic or cursory descriptions. If I were to injure my shoulder, and if I were to move my elbow beyond my clavicle, so raising my shoulder up, if that were to trigger the sensation of pain, what ultimately would I avoid doing? I would avoid lifting or raising my shoulder so that my elbow broke the plane of my clavicle. And so I would see now restriction in the linear range of motion of that joint, of those surrounding and supporting somatic structures, specifically the muscle tissue, because I'm trying to avoid pain. If something hurts, you tend to avoid it. Well, this actually now promotes neuroplasticity and tissue plasticity. So what do I mean by these two terms? Well, tissue plasticity is ultimately the response of connective tissue remodeling. If there are certain muscle structures that allow me to raise my elbow up, if I no longer utilize those muscle structures, then ultimately what transpires is a degradation of the structural integrity, density of that muscle tissue. Atrophy is the term that would describe this breakdown process. Now, in addition to the breakdown of the muscle tissue, then there is shortening of the connective tissue. Overall, this fosters an environment in which the muscle loses its viability. Ultimately, that will now further degrade the linear range of motion. I'm no longer limited in my movement because of a fear of pain. I'm now limited in the movement of that structure based on a lack of support mechanisms, based on a weakened muscle structure, based on a shortened connective tissue. Now, the second process that I mentioned is neuroplasticity. Well, all muscle tissue, skeletal muscle, is innervated with neurons. And those neurons are activated, those peripheral neurons are activated by the central system. And ultimately, there's the release of neurotransmitters that activate the action potential and then ultimately fire chemical cascades or changes along the synaptic cleft that trigger muscle contraction. Well, because my muscle has suffered a certain degree of atrophy, what is ultimately viewed is a change in the way not just the peripheral neural cells or tissue operate, but also the central system. There is a rewiring, if you will, of the nervous system to simply compensate for the lack of movement, to correct the body if there is an alteration in the way in one's gait, to simply avoid pain. So the nervous system is trying to rewire itself to accommodate the current system. So neuroplasticity in greater description is essentially these brain networks function differently in patients suffering from acute as well as chronic pain. There's a modulation in the somatosensory cortex resulting in functional reorganization. So normal patients generally transmit their pain through afferent nociceptive information through the thalamus. Primary and secondary somatosensory S1, S2, as well as insular and anterior cingulate IC and ACC. This is where pain is transmitted through in a normal individual. Where chronic pain patients demonstrate a decrease in these aforementioned networks. So the normal pathways in which the interpretation and sensitization of pain, those pathways that is ultimately utilized, there's an alteration. There is a decrease. Additionally, there's also an increase in the prefrontal cortex. So this is now associating pain with emotional cognitive processing. So what does that mean ultimately? Here we have neuroplasticity as a result of the pain adaptation model, rewiring, restructuring of the neural network. We're now involving more emotional and cognitive processes. So now pain is really an element of emotion, is now an element of our general cognitive process. So what in turn do you believe happens if you're more aware of pain? There's a heightened sensitization to pain. In fact, studies have shown that chronic pain patients, when exposed to a stimuli, there is a heightened degree of sensitization towards that stimuli. So there's a greater sense of pain, a greater experience of pain, higher thresholds of pain because of this reworking. And now there's that emotional element, so greater fear, greater overall degree of pain experience. So neuroplasticity can dramatically transform the way we perceive, interpret pain. So any future traumatic events, any future events that could trigger the sensation of pain, now we can appreciate that it'll be at a heightened degree. It's going to have a greater impact on that person's life. Here we see images of control subjects representing the normal subject, and then patients that are ultimately suffering from a chronic pain episode. We can see here that the indicators of temperature here, we ultimately are seeing a greater degree of firing, but more importantly, between subjects, control subjects, and chronic pain patients, we see different activation of different cortexes within that individual, a different mapping of the brain, if you will. And this is an indication of neuroplasticity, rewiring of the brain. And so now we see the activation of different structures within the brain And this is a beautiful illustration of what happens when we suffer pain. The pain adaptation model serves as the catalyst for tissue plasticity and neuroplasticity. And now we have a reworking of the neural networks, and ultimately the patient is going to perceive pain differently than someone that has not suffered from an acute or chronic episode of pain. Tissue plasticity, as we discussed earlier, is essentially a modulation or change in the structural integrity of the muscle, and that stems from or derives from aberrant muscle movement, which alters the mechanical demands on connective tissue. So essentially, the pathological remodeling of the somatic structure, the skeletal muscle. So essentially, the immobilization, this is, as we discussed, induces the loss of muscle length, subsequent to connective tissue contracture, also the loss of muscle density. So ultimately, now there's also an upregulation or increase in connective tissue fibrosis. This is going to induce or promote tissue stiffness, further impairment, also upregulate inflammation. The mechanosensory and nociceptive neurons are affected directly, not only through the connective tissue fibrosis, but also an increase in pro-inflammatory cytokines. So overall, we're seeing the grave effects that allowing pain to linger and allowing limited range of motion, linear range of motion, what this can do, the environment that it fosters and cultivates, how we see neuroplasticity and tissue plasticity inspire. These are images from a clinical trial and an overview of tissue plasticity and neuroplasticity and the types of changes that can be observed. So essentially, the first image at the very top is that there essentially is an activation, a spread of excitation of nociceptive neurons. So we see now the pain or issue of activation was isolated to a small area, has now spread to a greater area. Functional plasticity, ultimately we see that ion gates activate or initiate differently. There is ion channel sensitization. So now when an action potential is fired, there's more gates open up, greater intensity of these gates. This ultimately stems from inflammation, but ultimately you see now greater activation. Stimuli does not need to be as intense. So now a smaller degree of concentration of stimulus can activate neurons, and then this is transmitting that pain. Synaptic strength, ultimately we see that, let's describe the synaptic gap very quickly. It's the interface of two nervous structures, neuronal cells. One neuron releases the neurotransmitter. The neurotransmitter travels across the synaptic cleft. It begins to bind to receptors on the adjacent neuron, so that as these neurons are connected across the synaptic cleft, one releases the neurotransmitters, the other binds and reacts to that neurotransmitter. Well, what we see here is that following an incidence of pain, there is the neuroplasticity, and we see that a greater degree of receptors are found on the activating or the essentially the neuron associated with the synaptic cleft. And because of the greater degree of receptors, that means that the neurotransmitters that are being released have more targets to bind with, and that means that increases the likelihood of activation and continuing that signal across the body and ultimately the interpretation of. So here we see all of these elements feeding the experience or onset of pain, that these elements of hyperactivity of neurons, upregulation of inflammation, degradation of tissue structure based on a traumatic event, what we're seeing is the pain adaptation model. Tissue plasticity is further degrading the support structure, the somatic structure, the neuronal network, the brain network. The central nervous system is rewiring itself to compensate for the somatic structure degradation. Again, all of this is fostering an environment of this acute and chronic pain. In fact, these elements actually show the increase in chronicity of pain. So now we're ultimately introducing a technology, the Erchonia medical laser, that is designed to serve as a multifaceted approach for the treatment of pain, addressing the traumatic event, the very event that caused or activated the acute onset of pain. Now, dealing with the pain adaptation model by resolving pain, supporting the underlying traumatic events, it's the regeneration of that tissue, and ultimately restoring linear range of motion to ensure that tissue contracture, neuroplasticity do not take place following the onset of the pain adaptation model. And the EML device is able to accomplish this by administering low-level laser. Low-level laser is a unique parameter of light energy that allows for the photons, the packets of light, to permeate the skin structure, reach deep down to the skeletal muscle layer, and to activate specific photoreceptors. And these receptors are essentially molecular structures capable of absorbing light. So the image that we're showing here, very quickly, this is from a peer-reviewed publication, published in Dose Response in 2009, Volume 7. These researchers outlined essentially the mechanism of action of low-level laser. And it starts by stimulating a photoreceptor. And this photoreceptor is found in the cell's power plant, known as the mitochondrion. Inside of the mitochondrion is a receptor that helps to drive ATP, or adenosine triphosphate synthesis. And ATP is a very important biological catalyst in the cell, driving or activating numerous, plethora of biochemical reactions within the cell. Additionally, by increasing ATP, there's also an increase in reactive oxygen species, or ROS. And this is, as depicted here, the image that's going to activate as well specific biochemical reactions. So we see here, by stimulating a single receptor with laser, we're able to initiate what is known as a secondary cascade or signal transduction pathway. This in turn is going to activate enzymes, ultimately affecting the way genes are expressed, the way proteins are synthesized, and overall modulating cell function and behavior. So specifically, the Erchonia medical laser, the EML, administers a 635 nanometer wavelength, a very distinct wavelength within the visible red spectrum. That activates the mitochondrion-based enzyme known as cytochrome C oxidase. Upon stimulation with the EML, we see an increase in ATP and ROS production. Those molecules activate specific enzymes, and those enzymes activate enzymes, and so on and so forth, creating this intracellular cascade event. Ultimately, we see that these intracellular molecules or components activate effector proteins, and these effector proteins are what actually influence the way genes are expressed, the way proteins are produced. These are the elements that affect cell function and behavior. So by stimulating one receptor, we can affect, through these pathways, we can affect the way the entire cell behaves and functions. This is not a new concept. This is not a new mechanism. There are many, many drugs on the market today that utilize this type of activation or this type of mechanism, and they're known as agonist drugs. Agonist drugs affect a single receptor, and upon activation or influence of that receptor, we see activation of intracellular signaling proteins. Those activate effector proteins, and then those in turn affect cell function and behavior. So when I consume a drug, an agonist drug, it is broken down in my digestive system. A specific molecular component is absorbed that permeates or traverses my circulatory system, seeking out a very specific cell surface receptor, or perhaps an intracellular receptor. Regardless of the endpoint, essentially what happens is that molecular structure is unique, and its unique conformation allows it to recognize, one, and bind with, two, a specific receptor. So its molecular conformation is preventing it from binding to other receptors, but is permitting it to bind to a single receptor. Once that, and it's referred to as an extracellular signal molecule, once it binds to that receptor protein, there is now an activation of intracellular signaling proteins. Think of this as a game of telephone. You whisper in one friend's ear, he or she whispers in another, so on and so forth. The message is now making its way through a group of people. In the cell, this message that's being transmitted is ultimately going to affect or activate effector proteins. And these are the proteins that now alter cell metabolism, that alter gene expression, that alter cell shape and motility. So with a drug, the agonist effect, one molecule, one receptor can have a profound effect on cell function. Now, we would think that, okay, well, if an extracellular molecule binds to this cell with a specific receptor, and then there's another cell with the same exact receptor and it binds to that cell as well, well then we must have the same biological outcome transpire in these two separate cells. So drug A binds to this cell with this receptor, binds to another cell with the same exact receptor. We should see a similar response. Well, that's not the case, because each cell is unique in its concentration of enzymes and proteins. And so the image is really identifying how unique these reactions can be. Let's look at the image on the right, the furthest portion, the furthest illustration. We see basically almost a river with many different tributaries, bifurcation. So we come up to an element, a divide, where we can go left or right, or perhaps stay straight. And so what is dictating the stimulation? What is dictating that this little ball here goes right rather than left? What dictates whether the ball should go straight or not? Well, ultimately, many biochemical reactions within the cell are catalyzed, meaning that there is a structure or a molecule or protein or element, essentially, that is going to determine whether a reaction proceeds, and more importantly, based on the concentration of a given enzyme, determines whether a specific type of reaction is going to proceed. So here we go, back to our image. We have the uncatalyzed reaction. Basically, this stimuli is ready to go. It's ready to go out into the cell and activate a reaction. But does it activate reaction 1, 2, 3, or 4? Well, the concentration of enzymes is going to determine that. So if there is a certain demand in the body, if there is let's say there's a traumatic event and the cell's impaired, and there's a higher degree of enzymes related now to tissue repair, to cell repair. Well, because of that increase of an enzyme, there is now a propensity for reaction 1 to take place above 2, 3, and 4 because there's a higher degree of that specific enzyme. So reaction 1 takes place. And so we see now that the EML has a very unique response. It is able, under very harsh circumstances, oxygen deprived, hypoxic, ischemic conditions, to go in, stimulate a specific receptor, and now, based on the conditions of that cell, activate very important biochemical cascades that promote tissue regeneration. So because that enzyme is present in the photo target is present in all cells that possess a mitochondrion, the unique stimulation and subsequent reaction is going to be unique in each different cell. And a good example of this is acetylcholine. If I were to look at activating my skeletal muscle for greater contraction, then acetylcholine is my go-to neurotransmitter. That's what's being fired or released across the synaptic cleft. That's what promotes tissue contracture, tightening of that tissue. Well, if I now introduce acetylcholine to smooth muscle, what happens? Well, in fact, I don't see contracture. I see the complete opposite reaction, relaxation. This is common in vasodilation. The reason why we have vasodilation is acetylcholine is released, and ultimately there's a relaxation now stimulated, and blood vessels dilate, and more blood can penetrate or permeate an area. So here we have two receptors respond to acetylcholine the same way, but because of the unique cell structure, a skeletal muscle cell responds differently compared with a smooth muscle cell. So we're able to utilize the specific concentration of laser, and knowing the state of an injured cell, of an impaired tissue, go in there and really drive a very specific reaction that promotes regeneration, downregulation of pro-inflammatory cytokines. So in a very clear image here, sequence of image and very succinct description, the EML technology is able to target a specific receptor, activate that receptor. This activates a signal transduction pathway, which ultimately will modulate or affect effector proteins. That in turn will alter the way the cell ultimately its metabolism functions, its genes are regulated, and the cytoskeletal of that structure. So that's referring to cell shape and movement. So here we see, by using a very specific output parameter of laser, we're able to modulate cells in very unique and different ways. And we see in a wound environment or an impaired environment in where there's a manifestation of pain, we see that low-level laser therapy, the EML device, is able to activate the photoreceptor. The photoreceptor now transmits this signal throughout the cell, and we see the cells plagued with inflammation and oxidative stress, that when we activate this mechanism, the EML is able to modulate the transcription factor, nuclear factor kappa beta, which now in turn reduces prostaglandin production, which again in turn reduces overall inflammation. So by simply stimulating that photoreceptor, the EML is able to shift the intracellular redox state, which affects the regulation of cyclooxygenase 2, which is abbreviated COX-2, and that is responsible for the synthesis of pro-inflammatory cytokines. So again, stimulating a receptor with the EML allows us to modulate the intracellular redox state by producing reactive oxygen species, That in turn alters the regulation of COX-2, which downregulates pro-inflammatory cytokines. At the same time, however, we're also seeing not just serving as a COX-2 inhibitor essentially, but at the same time by releasing ATP, we're able to activate nitric oxide synthase, an enzyme involved in a pathway that results in the production of nitric oxide. Well, what do we know about nitric oxide? Nitric oxide promotes vasodilation, activates the synthesis of vascular endothelial growth factor. Now we're getting the opportunity to promote angiogenesis or neovascularization, which is basically the synthesis or establishment of new blood vessels. Activates the PI3 kinase system. This generates, as I mentioned, nitric oxide, and we're able, through all of this, now delivering greater blood flow, nutrient flow, oxygen flow, removing ischemic conditions, hypoxic conditions. We're able to now promote a healthier environment for tissue regeneration. All of this by delivering a single wavelength at a specific power output. And here we see some of the studies that have been published looking at this very parameter of laser energy, ranging from the treatment of acute and chronic wounds, nerve regeneration, tendon repair, cartilage repair, bone regeneration. Now, obviously, we're not promoting these treatments, but when we're now looking at the body of clinical evidence that shows that, yes, when you introduce this parameter of laser, you get acute treatment of wounds. You get chronic wound closure. You get nerve regeneration, tendon repair, cartilage repair. These are all great and very groundbreaking studies. But ultimately, what we're looking at now is if all of these elements are happening, and we are seeing the profound effects of the EML device or a similar output parameter of laser energy, we're seeing the profound transformation of tissue quality, tissue structure, then we begin to understand how it's able to affect acute and chronic pain by activating the same photoreceptor and changing the same signal cascade or secondary cascade within cell structures as observed in these studies. We're seeing these changes, and this allows us to appreciate and understand how this therapy could serve as a viable solution for acute and chronic pain. To prove the clinical effects of the EML device for the treatment of acute and chronic pain, a placebo-controlled, randomized, double-blind, multi-centered clinical trial was performed. Why perform this type of trial? Well, this is the type of trial that all pharmaceutical companies must perform to demonstrate the clinical utility of their pharmacological agent, their drug. A placebo-controlled, double-blinded, multi-centered, randomized study adheres to the tenets of evidence-based medicine, which is the pursuit of researchers, of clinicians to evaluate objectively the utility of a medical procedure. So we want to have certain controls implemented to mitigate the influence a confounding variable may have. We want to remove these confounding variables so that we have the purest assessment of a particular procedure. So a placebo-controlled study means that the subject has no idea whether they're getting a real treatment or a sham treatment. Double-blinded is referring to the fact that not only the patient is blinded to the type of treatment they're getting, but as the physician evaluating them is also blinded. So the physician has no idea what treatment they're getting, and the patient has no idea what treatment they're getting. Multi-centered is obviously very clear-cut, incorporates numerous centers, diversifying data collection across a given country. And then finally, that last term was randomized. Well, what does randomized mean? The subject does not know their group allocation. So a nurse doesn't say, oh, by the way, you're in the test group. That removes this whole idea of placebo control. So randomization is that a subject's randomly assigned their group allocation, and throughout the entire study they have no idea whether they're getting that real treatment or that sham treatment. And under these austere parameters, the Erconia medical laser was able to demonstrate a statistically significant change in a person's rating of their pain. So very quickly, how do we rate pain? We utilize the visual analog scale. Basically, we rate our perceived pain between a score of 0 and 10. 0 being no pain, 10 being the most excruciating pain ever experienced, just requiring some type of management, very high level, high degree of pain. Now, the scale used was not 0 to 10 in this particular study, but 0 to 100. So, very benign in the score or number assignment. But generally, we see in the clinical setting, we see scores between 0 and 100. So now looking at our study, a total of 86 subjects were enrolled. The test group, which totaled 43 subjects, had a baseline score, baseline visual analog score, so rating the degree of pain, a score of 60.21, and the control group or sham group 60. After a single treatment with the EML, treating the site of pain, as well as the corresponding nerve root for promotion of tissue regeneration or a reactivation of proper neurons, subject pain saw nearly a 29.02 reduction in the visual analog score, going from a 60.21 to a 31.19. Now, how did the control group fare? The average reduction was 4.91, not a statistically significant change. So this is great evidence, very strong evidence that a patient blinded of the treatment protocol when receiving real laser shows a dramatic improvement in their overall severity score regarding pain. Now, it is certainly one thing to have the reduction of pain, but we spent the better part of the first portion of this presentation talking about neuroplasticity and tissue plasticity, and what was a major driving factor to the onset of tissue and neuroplasticity. The pain adaptation model. My fear of lifting my shoulder up above the plane of my clavicle. If it hurts, I'm not going to do it. And so linear range of motion is something now that's compromised. So these are chronic pain patients in this study that have now suffered with chronic pain, and the chronicity ultimately has hindered or altered the integrity of their tissue structure. And so now they're going to demonstrate an impaired linear range of motion. When we look ultimately at the difference between the treatment group and the sham group, we see a dramatic improvement in linear range of motion. And when we look down at that chart here, we see here that range of motion for, let's say, the right shoulder was 128.8. So this is looking at the degree of rotation and degree of linear mobility, and we see that when we have a single treatment with the EML device, the linear range of motion goes from 128 to 144. Across the board, there's improvements in linear range of motion. Profound change. And not only that, these are statistically significant changes. And when compared to the control group, there's a statistically significant difference, reinforcing the utility of this medical procedure. Now that we see that the EML reduces one's pain by activating the photoreceptor and changing the biochemistry, we also see now by reducing the pain, helping to promote some degree of tissue regeneration, that there's an improvement in linear range of motion. Why are these two things important? Improving linear range of motion and reducing pain. Why are they important? Because numerous studies have discussed the concept of the pain adaptation model. And if a person does not get immediate improvement in linear range of motion, does not get the physical therapy care to continue to exercise and activate those muscle structures, what happens? The muscle shortens, fibrosis kicks in, pro-inflammatory cytokines increase, the neuronal system feeding into that injured tissue structure, that's changed because of the pain adaptation model, the fear of pain. Now there's a reworking of the entire neuronal network. What do we see? We see the transition of acute pain into the chronic characterization. So Langevin et al. In 2006 reported in a clinical study that in order to prevent the transition of acute to chronic pain, in order to effectively treat chronic pain, we need a multifaceted approach. We need physical manipulation, management of pain, so that we can continue to exercise the muscle without aggravating or promoting pain. The EML device, by reducing pain. The EML device, by improving linear range of motion, tackles the very elements outlined in the Langevin et al. 2006 publication. It reestablishes movement, and it does this by reducing the pain and promoting regeneration. So in summation, we look at pain today. It's a complex condition with a complex and elusive pathogenesis. Modern therapies or modern forms of pain management simply include masking the pain, blocking the pain without actually promoting tissue regeneration. So these analgesias, these pain medications, are there to silence the pain, to mask it by decreasing the sensitization of neurons. Overall, this isn't promoting regeneration. This isn't upregulating blood flow. And these are very important elements for tissue stability. And these are elements that through two separate placebo-controlled, randomized, double-blinded, multi-centered studies that the EML, the Erconium medical laser, has been able to promote reductions in pain, promotion in tissue regeneration, so that ultimately this procedure has the ability to restore quality of life, to improve overall recoveries. So whether it's a chronic pain from a traumatic event, such as a car accident, or pain, acute pain stemming from a surgical procedure that could perhaps evolve into chronic pain, the EML is there to mitigate that evolution, to provide tissue regeneration, promote improved blood flow, improved oxygen concentration. And his experiences and these experiences ultimately are providing that avenue. So it is a unique approach, a multifaceted and multidimensional treatment for or a treatment of pain. So with that being said, hopefully that the time constraints we generally see with these presentations, the time constraints did not accelerate the message, and in that acceleration did not alter the integrity of the message, that there was still a succinct and clear and lucid message overall, the mechanism of action, the differentiation from other pain management therapies on the market, and the more holistic approach in which now we're not only fixating on reducing the pain, but tissue regeneration as well to promote the greatest form of care possible. So with that being said, just thank you very much, and if you do have any further questions, please do not hesitate to contact our organization. Thank you.